This is Audible Bleeding, the Vascular Surgery podcast. We're here to help you keep your finger on the pulse.
Welcome to Audible Bleeding. This is Nicole, and I'm here today with my co-fellow Adam and Dr. Alozi. Today we are excited to have Dr. Michel Makaroun as our guest. Dr. Makaroun is a professor of surgery and the chair of vascular surgery at the University of Pittsburgh Medical Center. He is the current president of the Society for Vascular Surgery and has been the president of almost every major vascular surgery organization, including the WFVS, the SCVS, the Eastern Vascular Society, and the APDVS. He received his initial medical training at the American University in Beirut and vascular surgery training at Pittsburgh. He is an expert in the endovascular repair of aortic and carotid disease.
So, Dr. Makaroun, what brought you to vascular surgery?
I trained in general surgery and finished my training at the University of Pittsburgh. I liked a variety of subspecialties, but what ended up essentially making me do mostly vascular surgery was one of my mentors, who was the chairman of surgery at the time. And I grew up during an era when your mentor suggests something and you take it more than a suggestion. He suggested to me that they have a need for a new vascular surgery service at the VA hospital that was associated with the university. And he said that would be a good thing for you to do next year. And that's the way it happened. I started the vascular surgery service at the VA.
Who was your mentor, Dr. Makaroun, at the time? Who was the chairman of surgery?
That was Dr. Henry Bonson. He was the chairman of surgery from 63 to 87 at the University of Pittsburgh. He came from Hopkins. He was a cardiovascular surgeon. He did several firsts in the United States, from both in the thoracic aorta and the abdominal aorta. When at the time I was looking for a faculty position in the United States to be able to extend my visa, he suggested firmly that this would be the best opportunity for me because they really needed it, and he thought that I would be good at doing it. So I became a vascular surgeon.
What's a little bit of your background in medicine so that people can get to know you a little bit better?
I like to mention sometimes that a lot of our choices in life are not necessarily well thought of. A lot of random events end up influencing what you end up doing. I grew up wanting to be an engineer. I did not want to be a physician. I graduated from high school a little bit early. I was 16 and was dead set about going to Paris from Lebanon and enroll in one of the engineering schools that I was dreaming about, which was the École Polytechnique in Paris. But my father did not think that a 16-year-old should travel to Paris on his own, so he would not sign on my passport application. So I ended up having to stay in Lebanon. And he suggested that I could consider the American University. That's how I ended up registering at the American University. And on the first day or during the registration, they asked me, I remember, what kind of major do I want to declare? And my response was, I'm not staying here very long. I'm here for only 2 years. Do you have a major I can finish in 2 years? Because of the way the educational system in the United States was and in Lebanon, which were different. In Lebanon, it was mostly the French system. There was only a program which was called the pre-medicine program for 2 years. And the response was, you can enroll in the pre-medicine program for 2 years. And I said, great, sign me up. And that's how I ended up ultimately enrolling in medical school. Later on, I considered a variety of residencies and ended up settling on surgery because I was fairly interested at the time in pediatric surgery. The war was getting longer and longer in Lebanon, and we decided that we would come to the United States and finish our training, both me and my wife. And that was something very common for the graduates of the American University of Beirut. So the law changed in 1978 from a very open system in the United States that allows foreign medical graduates to come here almost at will, to a system where it actually tries to keep them out as much as possible. So I tried my best to come here, and the only limitations at the time was that you could only train for 2 years and can be extended only to 3 years, which would make a residency in surgery almost impossible. So I enrolled in residency in Beirut, and after the third year, I was trying to find a position in the United States. And because I was interested in pediatric surgery, ultimately, there was a symposium in Pittsburgh for the retirement of a well-known pediatric surgeon at the time, Dr. Keysweater. So I came and I attended the symposium since I was doing a rotation in Syracuse, New York. And at the end of the symposium, there was a dinner. And of course, it was all attended by a long list of pediatric surgeons from the United States. But Dr. Bonson, who was the chairman of surgery, ended up attending the dinner because he wanted to welcome everybody. But he really was not part of the crowd. So he was at the bar having a drink. And since I did not know anybody, I was also at the bar having a drink. And we started chatting. And after 2 hours, I had a position offer here in Pittsburgh, and I came and never left.
And, since you've been at Pittsburgh, you've built a great academic surgery career and really led to be the leader of, at some point, most of the major vascular organizations in the U.S. So what have you said is something that's made you successful and helped you be able to stand in these leadership positions?
I would say one is the typical immigrant mentality when you come to a new country, especially the United States. There's a very strong impetus to try and improve yourself. There are a lot of funny stories that accompanied my first couple of months in Pittsburgh that prompted me to try to work harder than anybody to make sure that I am not viewed as somebody who does not deserve the position of being here. I learned a lot from some of the big figures in surgery who were in Pittsburgh at the time. Dr. Bonson was a gentleman who didn't talk too much. This one I did not learn from him, but I did learn to be very direct and very honest in my opinions. Dr. Starzl was also here at the time, persisting in trying to promote liver transplant surgery. And early on, there was a few disasters and a lot of difficulties. But I've never in my entire life met somebody as persistent when he was convinced that what he was doing is the right thing. And I learned from him the persistence. And I think that really helped me a lot in my career. I never take the first no or the second no or the third or fourth no for an answer. That ultimately does result in some rewards. I also was influenced a lot by Mark Ravitch, who was at the tail end of his career, but still extremely bright, spoke several languages, and really had a big open mind for innovation and was very critical of the usual common narrative that we always feed to each other. He's the one who brought staplers in the United States. He wrote the history of the American Surgical Association, and it is said that everybody shuddered when he stood up to make comments or discuss a paper because he was very direct and always found the flaw in the arguments that were being presented. So I learned the critical thinking from Dr. Ravitch, the persistence from Dr. Starzl, and the direct honesty and hard work of Dr. Bonson. And I'm sure a lot of these things, in addition to being a fresh immigrant, helped me probably work harder than I would have liked to.
Dr. Makaroun, I have been lucky enough to know a lot of your mentees. A lot of your trainees had some interaction with Sina over the years, and I think the characterization of you being direct and hardworking is really very accurate. How do you recruit people to come and join you? Because you've managed to build a really big department and draw people to Pittsburgh, which is I think a testament to you and perhaps a challenge. And what is it about the department that has made it such a vital place?
I guess when you recruit people to join you, they have to share your vision. You have to be able to understand their goals and their needs and decide whether you can actually meet those goals or needs. And at the end of the day, you have to probably grow internally some of your future stars. When I started with the fellowship at the early stages, when I took over the division of vascular surgery in Pittsburgh, The prevailing notion in surgery in general and in certain parts of our institution is you never train your competition, that if you start a fellowship program, all you do is having more vascular surgeons around you who will ultimately share your pie. I really never quite got the logic behind this. So I was firmly convinced of the opposite. So I started our fellowship program and then the residency when it came about. And of course, we did not keep 54 of the 54 trainees, but we kept a fair number. And there are always people who wanted to join, and we also had the talent to offer them jobs. I think at the end of the day, also the most important facet that people are looking for is fairness. If you become known for being fair and treating everybody with the attention that they deserve, then a lot of people are willing to put up with a fair amount of hardship to be able to achieve the same goal that you are trying to set yourself to do. So I think all in all, having the talent around, trying to be fair to everybody, and at the same time, our health center has seen a tremendous amount of growth, which also provided for a lot of opportunity, has helped me in being able to recruit a fair number of people to come and join us in Pittsburgh.
So as the current president of the SVS, we wanted to hear what's coming up this year in the vascular annual meeting, as I'm sure you've been busy preparing for it.
Well, you have very much the traditional offering of the scientific program with the multiple abstracts and the selection that the program committee has put together. And they have, again, a very good, solid program from that perspective. We have some new offerings in terms of programs designed for some constituencies of the SVS that we did not always particularly attend to, such as the outpatient labs that have been mushrooming around the country, and there are a fair number of vascular surgeons who now practice a fair amount of their total volume in a totally freestanding facilities. That brings in a fair amount of different calculations as to how to do it, different challenges in terms of supplies, procedures, and what actually makes the outpatient labs work. We have an outpatient lab section of the exhibits that will help people who are interested find out what is out there to help them in this area. We have now programs for nurses and PAs. You know, the SVM started last year meeting with us at the VAM, and that is now expanding to other societies. And we are hoping that by next year, we'll also have additional societies joining us at the VAM. We have instituted a new social gathering that was always missing, I thought, from our national meeting, which is going to be on Friday night. And all of you probably have heard about it by now, which will be the gala dinner to raise funds for the foundation and provide a venue for all of the vascular surgeons attending the VAM to get together. Unfortunately, the gala is sold out and we will not be able to have everybody attend. So it's a shame, but the venue can only accommodate about 550 people. So I'm looking forward to seeing that first event and hopefully raise some money for the foundation. The VAM also will have a variety of other postgraduate courses, including the typical VQI day on the day before the event starts. We have a fairly extensive program for the fellows, and for the first time, we have a special program for the fellows and residents, in addition to what we used to offer for the medical students and general surgery residents who travel to the VAM, trying to entice them into a career in vascular surgery. So we have a lot of offerings, and I'm all excited that it's going to be a great meeting. I just wish I can attend most of it. As you know, I end up being shepherded into a lot of small meetings that prevent me from enjoying the entire meeting, but that nothing that prevents you from doing so.
Well, that sounds really exciting. Any hints to what you might be discussing during your presidential address?
This is something that actually I've struggled with a lot, but you can bet that the workforce issues that we are facing will be at least part of it.
That's interesting that you bring that up, Dr. Makaroun. We were hoping that you would talk to us a little bit about your impression of the workforce problem that's impending and what you think some of the solutions for it are.
If you were present last year at the Critical Issues Forum, you probably know my feelings about this. I believe that this is probably the most critical challenge that we face as a specialty, especially if we view our role as the society that's supposed to be looking for the provision of vascular surgery services across the United States. We have a problem that is not the product of the last year or two. It is a chronic problem that has been getting worse. It has been getting worse because there's more consumption of clinical services in the U.S. There's a lot more diabetes, obesity, and the demographics of the population is changing towards a more elderly population compared to what we had in the past. The baby boomer generation has started hitting retirement age, and the expectation is that the percentage of the population over the age of 65 is going to enlarge significantly over the next 10 years. So the need for vascular surgery services is going up tremendously, but at the same time, we are having a problem with the retirement of the generation that was providing vascular surgery services over the 80s and early 90s. And that generation was mostly general surgeons who ended up devoting themselves to vascular surgery, or general surgeons who also did some part of vascular surgery in the community. In our most recent survey, we confirmed what we have known for a long time. Over 40 to 45% of our membership in the SVS and of practicing vascular surgeons is over the age of 55. And unfortunately, a third of vascular surgeons retired before the age of 65. They retired around 60, 61. So we are expecting a big drain of our current workforce. And at the same time, we are unable to increase significantly the number of trainees that we are generating. The fellowship programs, which is what most people refer to as the 5-2, has been treading water for a long time. We typically offer somewhere between 115 to 125 positions every year. This is about the same number of applicants. Some years we have a little bit more, some years we have a little bit less. And many years we go without filling all of the positions. We also now have in the neighborhood of about 62 or so residency positions. But the rate of increase of the residencies has slowed down significantly. So I hope that we will be able to increase those residencies in the future, because on the fellowship side, we cannot increase it tremendously because the number of applicants are not there. On the residency side, we can probably increase it a lot, but then we will have the challenge of recruiting more medical students into the specialty. I think that's not a terrible challenge. We'll be able to easily do it because there's a lot of medical students in the United States who can be attracted as long as we start participating in their medical education a little bit earlier and try to mentor them throughout their formative years so that they would choose vascular surgery as their career. So for the last year, we've been trying to contact all the hospitals and institutions in the United States who do not yet have a vascular training program and encouraging them to support a new residency or a new fellowship if they can.
You think that the avenue for increase is mostly in increasing spots in the residency?
As you know, some of the programs who had fellowships have switched them to residencies. So the problem with that is that diminishes the fellowship slots. So we have to also keep encouraging new fellowships to start to keep accommodating all the general surgery residents who desire to become vascular surgeons. But the big growth is going to come, if we can, would be in the integrated programs, because we have a bigger pool of potential applicants that can ultimately join it. The problem with this also is even if tomorrow you start 10 integrated programs, it will be at least another 6 years by the time you add them to the match and actually go through the 5-year training program before they actually can join the workforce. So this is the best solution for us long term, but clearly it does not impact our immediate need for a few years. There's another problem that we have identified, which is a very serious problem, maybe even more serious than the total numbers of residency and fellowships, and that the distribution of vascular surgeons and jobs in the United States. There's probably several hundred jobs available. It's very hard to know exactly how many, but we are confident that it's several hundred. But the bulk of these jobs are in community hospitals that do not currently have vascular surgeons at all, or are underserved with one vascular surgeon who cannot recruit a partner, or retiring general surgeons who are still doing some vascular surgery and are about to hang it up. These community hospitals have trouble attracting vascular surgeons because most of the people we train tend to want to locate into bigger groups, being able to subspecialize, bounce ideas of others, discuss cases. They want better facilities. They don't want to be on call all the time. So most of these community hospitals are not able to attract vascular surgery care. They are relying more and more on interventionalists who can help but cannot provide the entire spectrum of the vascular care that a vascular surgeon can provide. And that's creating a public health issue, I believe, that is quite serious in the United States. So for that, we have been thinking hard about a potential alternative pathway for people who actually want to locate in community hospitals. They do not really care of being very specialized, and trying to see if we can provide this particular segment of the surgical population with additional vascular surgery training that will be adequate to allow them to perform some low complexity or low risk procedures at that level, being tied into a referral center that allows them both to bounce ideas off more experienced vascular surgeons and provide an easy referral to a higher level care when that is needed. We are definitely not at the conclusion of that alternative pathway definition, but we have a fairly decent idea about the general concept of how it's going to work.
Dr. Makaroun, that's really interesting because as a trainee going out into the workforce in the next couple of years, one of the scariest things is being out in an island where maybe you're working in an area with a lot of disease, but not a lot of actual support within reach or within the same institution. So would that support kind of come through the SVS or through the Board of Vascular Surgery, or what's the framework for how we can support these surgeons better in the community?
That is a very important issue you touch upon, and that will clearly depend on the local area where you locate your practice in the future. Currently, we do have community hospitals tied into our own system that we provide support for through review of cases because we have the same essentially PACS system. So it's very easy to pick up the phone and call us, and we can review the cases, discuss it together. We can provide support by reviewing of complications and making suggestions. We can provide support by actually traveling to some locations at certain intervals and help with some more difficult cases. And by actually integrating the people in those communities with our didactic conference and teaching environment. So we perceive that if we perform an alternative pathway, it will not necessarily be only for the trainees of the fellowship and the integrated program, but it will be also for the so-called alternative pathway, which is something yet to be defined properly, but it will not include a board certification with the standard fellowship training program that we are talking about. But as you alluded to, most young graduates feel the need of mentorship by senior individuals who can give them advice about particular cases. This is something that I see routinely even with our own graduates. sometimes with graduates who are located across the United States, not necessarily very close. And one of the stories I always like to tell is I know when my trainees are now completely confident when I stop getting their texts and their emails and requests for discussion. And that typically I get a lot of calls from our fresh graduates in the first 3 months. Then it starts dwindling down, and almost never after 1 year, as they form their own little network and they become more confident and they start believing in their skills as they go along. So it is clearly a difficult process to transition from being a trainee to being on your own, making all the decisions and bearing all the responsibility.
Dr. Makaroun, that's great that you've got that network of people that you've kind of figured out ways to support, and that you're looking at this problem too. One thing that we wanted to discuss with you is what the benefits are of being a member of the SVS, and if you think that that can play a role as well in helping integrate some of the people who are practicing in more remote areas. The
benefits are a lot. Actually, it probably is better to approach it from the other way around. Is there a benefit of not belonging to the SVS? And I would say that there's only one, which is not paying the dues. But that is a very, very short-sighted way of looking at it. The SVS provides also some financial advantages from a slew of benefits that people can subscribe to. But also it provides a community of surgeons that are actually trying to improve their specialty in general, whether it is at the coding, business side, government relations, or on the scientific side, and providing all the support for the educational aspects, whether it's postgraduate courses, to continuing education, to the VAM, the research aspects. So there's a multitude of programs that the SVS is doing that is of particular importance to the vascular surgeons. One of probably the critical importance is the quality programs that we have, including the PSO and the VQI. And it's important to participate in the VQI meetings and try to get the local comparisons that improve the way you are taking care of your patients. There are a lot of new programs coming up that will also improve the delivery of care, including something that will probably we start piloting this summer, and we will extend further in the future. And that is what we call the accreditation process that is not too dissimilar from how stroke centers and trauma centers are designated. And that will provide the services with a platform to negotiate with their institutions who would like to have designations to actually provide the services and supports and facilities that are needed to provide those services. The SVS also is providing a big push toward a evaluation study that would promote the value of vascular surgeons and trying to educate the consultants that are having a lot of discussions with our institutions and recommending decisions in the so-called vascular service lines. We are also getting involved with a branding campaign to improve the visibility and the definition of what a vascular surgeon is in the mind of patients and the medical community. The programs are endless, and the major benefit of being a member of the SVS is that you can become a volunteer and participate with any one of these programs that actually strikes your fancy and contribute yourself to the development of the future of vascular surgery in the United States.
Dr. Makaroun, thank you very much for that. That has been fantastic. One of the things we like to ask all our guests, and I think our listeners get a lot out of this, is if there's any specific technique that you have in your armamentarium that has gotten you out of trouble in the OR, any little instrument or technique or anything that you like that has saved you more than once that you can pass on to our listeners.
The only thing that gets you out of trouble in my mind is having a very good plan in your mind when you go into the OR and not pushing more than you think is appropriate for the to help the patient. Sometimes we get focused in the OR with the challenge of performing what we believe is what got us there in the first place, what we are trying to do. And it is fairly common for most surgeons to keep pushing until they try to do what they got there to do. It's very important to remember that you can actually change the plan, and you can decide whether that plan was necessarily appropriate in the first place. So I'm not sure I would call this a technique or I would call it an instrument, but it is a maybe state of mind that you have to have when you are in the OR. It's that you have to be able to switch your concept of what you're trying there to do. You always will encounter some unexpected anatomic features or physiologic problems, and you have to adjust what you're doing to the particular situation. In terms of strong preferences myself that I find that has helped my results in general is there was a saying a lot of the surgeons used to love to say, big surgeons make big incisions. And unfortunately, it's still a widespread belief that surgeons to live by, and that the exposure is never big enough. And I believe that actually results in some trouble in the OR because you end up dissecting too much, producing more physiologic changes. One of my beefs in the OR is to actually use the incisions that only are necessary to provide the exposure that you need to perform the procedure. Now, of course, this is the perspective of what is the exposure that you need. In my mind, it's much, much smaller than the exposure than most people do. So I never dissect the aorta circumferentially, for example. I never expose any part of the anatomy that I don't need to expose, that limits on the fluid losses, on the physiologic challenge that the patient has to deal with. So if there's any technique that I would recommend, I would say is it's not really the size of the incision that is going to help you achieve good results, but respect of the tissues and only dissecting the amount that you absolutely need to.
Yeah, I think that's good advice.
Thank you so much for your time and this discussion this morning. Anything that you want to leave our listeners with, any closing remarks or something that you find particularly exciting about vascular surgery that really all trainees should know about?
All I can tell you is that vascular surgery is definitely very exciting. It's probably one of the most rapid change that I've seen in any area. It's almost as fast as what your computer and electronics keep changing. Devices keep popping up every couple of months, and I, for one, cannot keep up anymore with all the new techniques that are available. What's very exciting about vascular surgery, too, is that it is becoming so large and vast that you can even subspecialize in vascular surgery and form an area of special interest. That actually will provide you with a lot of expertise in one area and a mastery of the techniques that you will be able to do. So it's a mistake to keep thinking of vascular surgery as the vast field that it currently is and think that everybody is going to be able to master all of vascular surgery. That is probably a dream that is no longer feasible. It's both exciting and great to start developing special interests in vascular surgery. Most people do that anyway, but it can really be modeled to the particular interests of the individual who is practicing vascular surgery.
Thank you again, Dr. Makaroun. This was fantastic, and we appreciate you taking the time.
I'll see you all at VAM.
We are Audible Bleeding, the vascular surgery podcast. Our team is committed to providing free, high-quality, unbiased content to our listeners. We currently do not take any funding from industry sponsors or advertising, and we hope to keep it that way. So if you want to help us keep bringing you great content, go to audiblebleeding.com/support and find out how. We'll put a link in our show notes.